Khair. Good evening, everybody. It's a pleasure to be back with you again. My name is Ibrahim Sbeih. I'm a neurosurgeon, and we are transmitting live to our international audience from Farah Medical Campus in Amman, Jordan. The topic for today will be sphenoid sinusitis with multiple cranial nerve pulses. It's a clinical, radiological, operative, pathological correlation. This is downtown Amman, center of Amman. And this is the Roman amphitheater and some of the stairs in the old souks of Amman. So if you have a property there in the center of Amman, you'll be rich. So whenever you are in the center, you will gain a lot. Sphenoid sinus is in the center of the skull. So it is the central bone of the skull, and everything is built around it. So this is the skull as a whole. This is just showing the sphenoid bone, which is composed of body, a lesser wing, greater wing, and two legs, the so-called pterygoid plates. It is surrounded by very important structures. And to deal with the sphenoid sinus, you have to know the relationship with all these important pituitary nerves, optic nerves, frontal lobes, cavernous sinus with its contents, the median canal, the sphenopalatine artery, sphenopalatine ganglion. So this is it. This is the sphenoid bone. A body, just like a bird. This is the head, this is the body, these are the wings. Large wing, a small wing, and the body which has two legs, which is the medial and lateral pterygoid plates. And inside the body is the sphenoid sinus. So this is it again, sphenoid bone, wings and the body, and the way through to the nose. Sella tersica is sitting on the body. On the top of the body, this is the body. On top of it is the sella tersica with the pituitary, and on both sides you have the cavernous sinus with the carotid artery inside, with the venous channels inside, third nerve, fourth nerve, first division of trigeminal, second division, third division, and the sixth nerve. So third, fourth, and sixth. The only one which is really inside the cavernous sinus is the sixth, while the third, the fourth, and the first division of trigeminal are on the wall of the cavernous sinus. V2 and V3 are not inside the cavernous sinus. Again, this is the cavernous sinus as you look at it from the front. So this is the sinus, and this is the endoscopic view of the sinus, which is full usually of septae. Lateral view of the sinus, the center of the skull, with the frontal lobes above, sella on top of the body, and the cavernous sinus. Larger view of the same thing, pituitary gland and the sella on top of the body of the sphenoid. Inside the body is the sphenoid sinus. And the pattern of air pneumatization in the sphenoid sinus is variable. This is almost lack of pneumatization. This is pneumatization in the anterior part. This is pneumatization on most of the parts. So that's why we get different kinds of sella tersica. Pneumatization starts at the age of 1 to 2.5 years. You start having pneumatization of your sphenoid sinus, and it is complete by the age of 10. Of course, this has an implication of transnasal, transsphenoidal surgery in kids. So this is the sphenoid sinus with multiple septae. This is pituitary gland, and so on. Same thing. And we have to appreciate that the sphenoid sinus may have a large lateral extension, the so-called lateral recess of the sphenoid sinus. And sometimes the sphenoid sinus also radiation goes into the anterior clinoid process like this. The anterior clinoid process is totally aerated. Look at the many septae here. And here is the foramen rotundum, here is median canal. So the relationship between both is very important for the endoscopists. There's a relationship between the ethmoid and the sphenoid. anterior ethmoid, middle ethmoid, posterior ethmoid. Posterior ethmoid is very much related to the sphenoid. And these are the kinds of pattern of both relationship. And this is the radiology, different radiology pattern of the relationship of the ethmoid with the sphenoid. So we know now the sphenoid sinus anatomy. What kind of lesions can we have there? Most of the lesions are inflammatory, 2/3 maybe. 1/3 and miscellaneous is neoplasm or miscellaneous. If we come to one topic, which is the mucocele, of course, the commonest with the air sinuses is the frontal, followed by the ethmoid, followed by the maxillary, followed by the sphenoid. So our topic for today is very rare. To have mucocele of a sphenoid is extremely rare, especially if it is associated with multiple cranial nerve pulses. What kind of inflammatory lesions do we see? You may have single or multiple organisms, you may have bacteria, you may have fungal involvement, actinomycosis, mycosis, aspergillosis, etc. The main thing in the mucocele problem, which may turn into pyocele if it got infected, is obstruction of the sinus ostium. So there is the sinus with this epithelium, ostium is closed, secretions continue, blocked, so they will accumulate and they will get secondary bacterial infection, purulent material, and then it will expand and cause bone erosion. Which countries are famous for the sphenoid sinus mucocele? Asia in general, China, Japan, North Africa, and Middle East. Look at the patterns of this mucocele of the sphenoid sinus. Look at this one. So they can get really extensive. Look at here, the destruction of the walls. You may pass this as nothing, but it may be very important. So here the lateral recess is involved. Look at the aeration of the lateral recess. Again, the amount of bony destruction here. The relationship of the foramen rotundum with the maxillary division and the median canal, which carries the greater superficial petrosal nerve. And here is the same thing, relationship between the foramen rotundum and the medially situated median canal. Median canal now is the landmark for the endoscopy. And I have always to mention that endoscopy lies the future of neurosurgery. So many papers published about sphenoid sinus mucocele. Not many, as I said, it is rare, but the ones I could collect are like this. Various papers. Mucocele involving anterior clinoid, as I said, because it is aerated as part of the sphenoid sinus, and then you will get just the mucocele in the anterior clinoid, and it will form the orbital apex syndrome or cavernous sinus syndrome. You may get fungal infection, and I want to share with you this patient of mine from Libya, 25-year-old, with this extensive fungal infection going intracranially. Look at the hypertelorism. This is the pre-op, and this is the post-op. Another case of mine with this fungal infection.
What type?
Yes, we'll get there. And here, this, again, Iraqi gentleman with fungal sinus infection complicated with the brain abscess. So it was aspergillosis. And this is actually your stains in the lab. Cases of fungal infection, they call it fungal ball because it's really like a ball, so it can go everywhere. Again, fungal balls or fungal infection, and look at the black debris of the fungus. This is very invasive fungal sinusitis. And here again, ball, fungal ball causing visual disturbances. Same thing here, ethmoid, sphenoid. Look at the bony destruction here and here. Treatment, I'm sure Dr. Muntasar Baldisi will allude to this, but basically to remember that amphotericin B is important, and recently hyperbaric oxygen. Of course, if the patient is diabetic or immunocompromised, you have to treat. What is the radiology of these sphenoid sinus mucosae? It really depends on the contents, because the content, whether it's mucus or infected with secretions, will cause biochemical constitutions. All in all, low signal T1, high signal T2, and usually no rim of enhancement. But of course, there are the odd things. So here you are, bony destruction. This is a patient of mine, a recent patient of mine. Look at the pituitary, how much it is involved. The cell is totally destroyed. This is T2. And you can see that there is suppression on ADS and the rest of it, as we mentioned. Comes the question, how often does isolated sphenoid sinus disease turn out to be neoplasm? How often you have a sphenoid sinus mucocele, but it is not caused simply by bacterial infection or by obstruction of the ostium. It is caused by more sensitive pathology. Let's see. You'll be surprised. Sphenoid sinus neoplasm presenting as mucocele. So don't be misled by this is simple mucocele, because it can be very nasty. And this is the idea of such meetings, that we shed a light on these cases that will interfere with the management. Carcinomas, papillomas, angiofibromas, etc., pituitary tumors, meningiomas, other lesions other than tumor, trauma, foreign body, post-op, post-radiation, aneurysm of the carotid in the cavernous sinus. Let's see. One of my cases, sinonasal pneumoma fibroma with obstruction of the sphenoid sinus. Another patient of mine from Sudan with this tumor blocking the sphenoid sinus. This is pre-op, this is post-op. Sphenoid sinus carcinoma, angiofibroma, especially in children, Ewing sarcoma, nasopharyngeal carcinoma, as we mentioned, giant cell tumor, Ewing sarcoma, I mentioned it, solitary fibrous tumor, reported in this series of 33 cases. Sphenoid sinus chordoma just centered in the clivus area. Multiple myeloma or single myeloma. I had about 4 cases of single myeloma in the clivus, in the sphenoid sinus. Cavernous hemangioma just in the sphenoid sinus. And rhabdomyosarcoma. You may, oh, this is simple. This is mucocele. No, this is mucocele complicating rhabdomyosarcoma of the sphenoid sinus. I heard something the other day. Why are you, Dr. Sbeih, presenting these rare cases? Because of this. You just, the talk about common is common is nonsense. Common is common, yes, it comes at the top of the list, but you have to know the rest of the list. Clivus metastasis, Hodgkin lymphoma. Where's the lymphoma man? He's not here today. This can follow, the mucocele can follow head and neck radiation for various types of tumors. This was complicating a case like this. It can be complicated by simple things, not only tumors, but a polyp. It will obstruct the ostium and cause mucocele. Fibrous dysplasia, and I have a few cases obstructing the ostium. This is one of my cases. Look at this. Obstructing it completely, obstructing the anterior clinoid, distorting the optic canal. Again, in an Iraqi patient. Lipoma intraosseous within the cavernous sinus. Rare things that we don't think about it, and there is always a word of warning for the young generation. You look into the nose or the throat of somebody and see something dangling, you take it out, and then you have either sudden death or CSF leak, because you did not remember the rare things. Encephalocele and meningocele presenting through the nose. I have seen cases like this. Sphenoid sinus mucocele caused by thrombosed intracavernous carotid aneurysm. Who would think of this? It is there. These pathologies are there, but you're not thinking about it because you think common is common. Nonsense. Common is common in the way of thinking, top of the list, but I should know the list. Aneurysm, bilateral. Bilateral. Not single, bilateral. AV fistula within the sphenoid sinus. Let's concentrate on the sphenoid sinus mucocele. Symptoms. This is very nice paper. Isolated sphenoid sinus pathologies, the problem of delayed diagnosis. This is absolutely true. And when we come to our case, you'll see there's always delayed diagnosis because common is common. We don't think about the rare things. That's why the sphenoid sinus is called the silent sinus. It is not like the frontal or maxillary. Common thing in our emergency department, I have a headache, you do this, oh, there's no sinusitis. No. Sphenoid sinus is deep. It will not give you the same thing like frontal or maxillary. But because you did not think about it, you will not diagnose it. Always delayed diagnosis. And who's responsible? GP, ophthalmology, ENT, pediatricians. And this is a good statement. Headlight and plain X-rays are not enough. Just to put the headlight, oh, there's nothing. Of course, there's nothing. You will not see pathology in the sphenoid sinus by putting the headlight on. What are the symptoms? Headache. Who among us never complained of headache? It's a common. And the common say in the Arab world is that, oh, I had these usual headaches that affects all people, and it is remedied by one tablet of analgesia. This is very dangerous. Most of the brain tumors I have seen were like this. How many? Oh, I used to have these headaches, but that the usual headache that everybody complains of, and it is relieved by simple analgesia, and it is caused by skull-base tumor. So you may present with headache, you may present with visual, meaning vision, you may present with ocular palsy, cranial nerve palsy, and others, exophthalmos, pituitary dysfunction, nasal obstruction, which is they're very rare. Papers about this. Isolated sphenoid sinus disease and overlooked cause of headache, which is absolutely true. And I would add another paper saying isolated sphenoid sinus disease with a major sensitive carcinoma and overlooked cause of headache. Where does the headache of the sphenoid sinus come in? Again, we just press here and there, we say no sinusitis. It could be anywhere. It could be bifrontal, it could be one side, it could be fronto-orbital, it could be occipital. What do you think of that? Occipital headache caused by sphenoid sinus. If you don't think about it, you will not diagnose it. Diffuse, generalized, retroorbital, all vertex. Hemicranial looks like a migraine or something. Bilateral consecutive blindness caused by mucocele, blindness, irreversible. That's why you should diagnose these cases. Don't say common is common. Blindness. Which nerve of the cranial nerves is mostly affected? There is debate. Is it the optic nerve or the third nerve? It's equal. Some people say it's optic nerve, some people say third, and so on. But this is a paper saying that we have bilateral blindness and it was irreversible. Sphenoid sinus mucocele simulating retrobulbar optic neuritis. Decreased vision, a young person, a female, hysterical. Females are usually diagnosed as hysterical because they are refined creatures. We over diagnose their refinement. Sphenoid sinus mucocele masquerading as retrobulbar optic neuritis. These are papers. Look at this going into the orbit. It will press on the optic nerve, cause ischemia or infection, and the patient will have total loss of vision just because nobody diagnosed sphenoid sinus mucocele. Mucocele of the sphenoid sinus, a rare cause of reversible third nerve palsy. It is really rare, and our case that we are going to present is exactly the same. This is before surgery, this is after surgery. But this is a paper, not of ours. We will discuss it when we come to our case. Isolated sphenoid sinus mucocele presenting as third nerve palsy. I would think of this. I want you to criticize yourself and say, do you really think of sphenoid sinus causing this? Which nerve? We said optic nerve is common, the other nerves, third is the commonest, and usually it is pupillary sparing, meaning that the pupils are not affected. Third nerve palsy could be pupil sparing, could be pupil involvement. Sentinel palsy, fourth nerve palsy, or fifth. Why fifth? Because first division of the trigeminal is within the cavernous sinus. Second division is just in the floor, so any of these can come. Again, imagine yourself treating a patient who says, I have headache and I have numbness in my face. No, nothing. Hysterical. Case of isolated absent nerve palsy caused by sphenoid sinus mucocele. Sphenoid mucocele presenting with oculomotor nerve palsy and affecting the functions of trigeminal nerve. Features of visual disturbances secondary to isolated sphenoid sinus disease. Sphenoid mucocele with unusual pan-hypopituitarism. Would you imagine this as a mucocele? And the patient has, in addition to the cranial nerve palsy, pan-hypopituitarism. So what are the complications? Why are we presenting this? Because of fear of complications, because of fear of somebody missing the diagnosis, not being careful enough, because common is common, rubbish. Common is common in the eyes and the minds of very superficial people who are not thinking, should not be in medical field actually. Complications, orbital abscess, cavernous sinus thrombosis, compression of the internal carotid artery, visual loss, meningitis, extradural abscess, subdural abscess, brain abscess. Are these cases real? Of course. This is one of mine, 3-year-old, presenting with this brain abscess. Extradural abscess. A paper with meningitis and a brain abscess. So this is real. This is not fictitious. Cavernous sinus thrombophlebitis, usually fatal. 80% of cases, they die, simply because you did not think about mucocele. This very nice paper from the University of California, Davis Center, Medical Center, with this cavernous sinus thrombophlebitis secondary to fungal infection. Look at this carotid artery, thrombosed, compare it with this one. And because it is affected on the left side, there is ischemia. So what's the treatment of these mucoceles? Surgery, basically, whether it is microscopic or endoscopic. I am a microscopic man, but surgery for the sphenoid could be very well endoscopic. And as I said, it is the future of neurosurgery. And the aim is to have an opening in the sphenoid. It is called marsupialization, and allow the drainage of. This is usually the case in Europe. In the States, they go a little bit aggressive, and they demand that you should remove the mucocele, which is really not practical. You may use image guiding, navigation. Anybody from the navigation? From Master Ziyad. You can use the navigation, you know exactly where you are. This is one of my cases, using the microscope, and just making a check, say this is the cellar, and this is to know where I am exactly. And the endoscopy, of course, you can actually reach from here, crystal line down to the foramen magnum. This is the future of neurosurgery. And these endoscopists are, I'm proud to say, they are friends of mine, I'm a friend of them. We meet and discuss matters frequently. And I am a member of the International Society of Pituitary Surgery, and that puts you in direct contact with these people. We fight, we argue, but with respect. Everybody has his own opinion. The major man in the pituitary is Ed Lowe's and Osiko. And this is wife of Ed Lowe's, this is my wife. And here we are in various meetings. Approaches to the sphenoid sinus, you can go transnasal, you can go transseptal, you can go transpterygoid, which is the new. It is mainly endoscopic. Transnasal, first choice, but if you have a lateral rhesus, then you go with the transpterygoid. Papers, endoscopic drainage of pediatric paranasal sinus mucocele. Pediatric. Endoscopic sphenoidectomy. Sphenoidectomy for this kind of lesion. Uterus apex mucocele, you can only reach it through the pterygoid fossa. Maxillary sinus, open the posterior wall of the maxillary sinus, you go to the pterygopalatine fossa, and from there you will reach the uterus apex. So we'll come to our case. Sphenoid sinusitis causing multiple cranial nerve pulses. HM, 31-year-old Jordanian. He's a graphic designer. He resides in Norway. He lives there and he practices his graphic design in Norway. He is the son of a famous general surgeon here in Jordan. And this case, surgeon. This case was back in December 2018, 6 months ago. He was treated at St. Elsewhere. We don't want to mention the hospital. That was why we call it St. Elsewhere. For 2 weeks, he complained of headache, severe. He started to develop some fever, generalized fatigue. بالجملة العامة. And يتعب شوية وعنده صداع متلوث شو زي. So he was given empirical antibiotics without any investigations, without any examination. Diagnosis, simple sinusitis secondary to flu. He was given antibiotics. After 1 week, he had right eye ptosis. Started to have double vision. He complained of facial pain and facial numbness because of V1, V2 involvement. And then he started to have nausea and vomiting, and he developed hematuria. Nothing in the past history. He had tonsillectomy as a child. Examining him, you will see a patient who is ill looking. He's moribund, really ill, and he was shivering with fever. And what do we diagnose? Hematuria and shivering, UTI, immediately. Because common is common. He had necrogytic. Nobody bothered to examine him. He had severe necrogytic. The cardiac sign was positive. He had meningitic signs. This patient was known to die. Fever? Yes, he was feverish. General examination was normal. Upper and lower limbs had no weaknesses. He had no weaknesses in his arms or legs. We started treating him, and he just pulled a little bit. This is just before going to surgery. CBC, etc. was well. Everything was well except the platelets low, and that goes well with the severe infection, DIC kind of thing. So we did a few images, and I want to ask Dr. Hoshe to present.
What was his CRP? Did you do a CRP?
Yeah.
We'll mention it. It was high.
Good evening. Sorry يا جماعة طالع. I'm coming out. اطلع هون. Just coming out from sinusitis بس مش sphenoid. فمشان كيف صوتي فيها شوية حظيرة. it gives me, being a member of Farah Medical Campus, I would like to welcome you all. I would like to welcome you all to this most fruitful and prestigious multidisciplinary neurosurgical conferences, organized by our friend Dr. Ibrahim Sbeih. Really, Dr. Ibrahim, I really thank you for your continuous and sustained effort in organizing such conferences. How long have you been doing this?
Those years.
Those years. I will take you a little bit. Can we have the images? Yeah. Okay. I will take you a little bit for 2 minutes away from radiology and neurosurgery, and then we'll come back. Okay. Now, during my years at the medical school, I had two weaknesses. One was in the neurosurgery anatomy, neurosurgical anatomy, and the other one was in pathology and histology. Right. So back when I was trained in the American University in Beirut, I was wondering how Dr. Fuad Sami Haddad, which you know, or Dr. Sbeih now, how would he know? How would he know all the relation between the tegmen and the sphenopalatine nerve and the pontine artery? How can he avoid such very, very delicate structures? And the other one, it was pathology and histology. How can a pathologist from a bunch of cells give me the diagnosis of grade 3 poorly differentiated oligodendroglioma? But now, after attending such conferences, and believe me, I learned a lot. The other point is when I got married at a late age. I think Dr. Jarir, you know?
Of course. You were 32, and then 10 years we were looking for the wife. So
well, I got married at the age of 42. Then my son Abdullah, when he was young, he used to tell me, Father, why do you attend? He used to cry and tell me, it seems that you are a good radiologist. Why do you attend conferences and travel and attend conferences? Why all this hassle? I used to tell him, look, Abdullah, when he could understand what I was telling him, I told him, my son, knowledge has no limits. One goes to grave and keeps on learning, and that's what we are doing now. Okay, now as Dr. Ibrahim said, sphenoid sinusitis is a very rare disease. Now, let me concentrate first of all on the images on the planes that we take in the neuroradiology. Always we have some images, Dr. Ibrahim. Yeah. Okay. All of you can tell about the. Everyone knows by now that this is the sphenoid, and this is the ossification of the sphenoid sinus. We'll come back to it, but always please try to take planes in different, images in different planes. That is sagittal, coronal, and axial images. Fine. Because as you know that the sphenoid sinus has intimate relationship with a lot of structures, important structures, such as the cavernous sinus, the carotid artery, and the optic chiasm, the supraorbital fissure, and a lot of other structures. Okay, and what can happen? What can happen in the sinuses? The diagnosis, it can be very easy and it can be very difficult. Very easy in the sense it can be sinusitis, or it can be tumor, or it can be fibrous dysplasia, it can be lymphoma, it can be anything. Because in the sinus, we have, of course, we have the mucosa, we have the ductal epithelium, we have the lymph, artery, vein, periosteum, and bone. Okay, so coming now to our friend, the sphenoid sinus. Let's go. One important thing, take-home message from me, please, that differentiates between chronic sinusitis. I had sinusitis. Why didn't proceed into a mucocele? One thing, he mentioned that obstruction of the ostium of the sinus. Okay, there is the blockage of the drainage of the sinus into the nasal cavity, and that's what happens. The sphenoid sinus becomes opacified. It expands. Okay, there's one lateral. Okay, it expands, and as you see, because of the blockage of the ostium, the mucosa of the sinus starts producing mucus, and the mucus blocks the ostium, and it becomes expansile. And if it's infected, it starts going again involving surrounding structures. Now, there's only one sign here of extra sinal infection extension, which is the pneumocephalus. Of course, this patient wasn't given contrast during CT. Of course, my friend Damad will show you the MRI images with the contrast, and will show you the extension beyond the boundaries, and he will show you probably the meningitis and the abscess and the edema in the surrounding structures. And so this is the, again, yeah, okay? Okay. Dr. Ahmad?
مساء الخير. I will concentrate on the MRI findings and not to speak out of the track. This is T1 weighted for the same patient. This is T1 weighted without contrast and T1 weighted with contrast. If you can see, there is a hypointense mass lesion, expansile, exerting some mass effect into both optic canal, also in the clivus, with some erosion, and also the cavernous sinus in both sides. Also, there is a small, this is a small hypointense lesion in the subdural area of the left temporal lobe, which may be due to reactive or extension of the infection into the left temporal lobe. This is with contrast. We have also here REM enhancement. We don't have soft tissue enhancement, just REM enhancement. And this is the maxillary sinus, also this is the maxillary sinus. Here, you can see also there is enhancement of the meninges. This is most likely due to secondary meningitis. And the relationship with the, here the carotid artery sinuses. This is the optic canal. The most important things, this one, which is very close to the superior orbital fissure. Superior orbital fissure carries cranial nerve 3, 4, 6, and V1. Next. This is post contrast meningitis. This is without contrast, and this is T2 weighted about the lesion. T2 weighted, the relation with carotid artery, optic canal, and there is an obstruction with posterior and anterior ethmoid sinusitis. T2 weighted. This is flare sequence. We can see the sinusitis with a lateral recess here, which reaching the optic canal. Next one. And this is the very important one, is the diffusion. Diffusion gives a restrictive pattern, which indicates an infection. I mean, could be an abscess. The only one which can give restrictive pattern is abscess. Next one. This is coronal, post contrast, optic nerve, and here we have two foramen, which is very important. The rotundum, which carries the V2, and also we have the oval, which carries V3, and we have the Viden canal. DCM. T2 weighted, this is the lateral recess. T2 weighted, DCM. But we have here very important sign. You can see there is an edema in the lower part of the frontal lobe. Here you have very tiny fluid. Next one. Edema, fluid, the same findings. This is sagittal T1 weighted with IV contrast. The most important thing is the rim enhancing lesion with gas bubble here, which indicates an abscess in the right frontal lobe. Next one. Sagittal T2 weighted, you have some here, there's some erosion or suturization of the clivus. Here you can, okay, the same. Next. This is very important. You can see this is the cella, and the bone, the floor of the cella is intact because there is a hypo-intense structure here. This is the bone. There's no extension into the pituitary gland, and this is the optic nerve. And you, I think this is free. This is the MRV normal. Just to summarize our findings, there is a hypointense expansile lesion in the sphenoid sinus, obstructing the sphenoid recess, with extension of the tumor into the front posterior ethmoid and anterior ethmoid. And there is extension of the infection into the right frontal and left temporal. Also, we have a relationship of the lesion with the superior orbital fissure. Thank you.
Another consultation, Dr. Mohammed Juma, endocrinologist.
Good evening, everybody. Yes. From endocrine point of view, I was consulted to evaluate pituitary if it is involved or not. Of course, here, if there is any destruction in the floor of sella torsica, the pituitary could be involved, and we are witnessed very nasty case previous to this one with pan-hypopituitarism. Very, very severe pan-hypopituitarism. Here, liver enzyme, it was high. It goes with infectious process, with septic process. However, we excluded also specific causes of elevated liver enzymes like hepatitis and HIV. All of them were negative. Next, please. CRP, it was high, 175, which is very sensitive marker or indicator of the severity of inflammation. It is very important. I think it is more informative than SRP. In infection in particular. Yeah. We did also pituitary function test. All of them were within normal range, but as you see, free testosterone, it was just below the lower limit of normal. FSH, it was low. Thyroid function, free T4 on the low side, TSH is normal. It goes mostly with euthyroid 6 syndrome. We call it due to severity of infection. Sometimes we face normal TSH, a free T4 on the low side, which we call it euthyroid 6 syndrome. We did not give him any medication, just follow. He denied any sexual problem. His wife was pregnant, I think, and we just give him a time for observation and to repeat pituitary function later. Yes. Thank you.
Dr. Mohammed has to leave, that's why.
Yeah. Sorry, I have a lecture.
Ask Dr. Hiba Barghouti, what's she? Dr. Hiba is a nephrologist, and she was asked to see the patient because of the high creatinine and hematuria and so on.
All right, good evening. So I was called to see this patient because of elevated serum creatinine. It was 1.7 in the previous institution or same center. It was recorded as 1.7.
You called it previous.
There are two components for his acute kidney injury. One was he was volume depleted, pre-renal azotemia. And the second one was heavy use of non-steroidal at the other hospital. So with the simple hydration and IV fluids and discontinuation of all non-steroidal, he had a complete recovery of his renal function. Workup included the renal imaging, which was normal. And subsequently, he recovered with creatinine going down to 1. His electrolytes were normal, and his urine analysis, which was initially with some RBCs, also completely recovered. So can I take this opportunity for one statement? Just a few words making use of gathering different subspecialties in one room. NSAID nephrotoxicity is not one entity. It's a spectrum of disease with different manifestations. A lot of us confuse this with what we call chronic analgesic nephropathy. If he used it for 3 or 4 or 7 days, how come he can get acute kidney injury from analgesia? He's not the prototype where you consider him as high risk for NSAIDs. He's young with no other comorbidities. But I need to focus on acute kidney injury from NSAIDs. It can cause, because only by hemodynamic changes, which happen in this man because of quick recovery, it can have other forms like acute interstitial nephritis. It can even cause nephrotic syndrome from membranous or glomerulonephritis, and it can cause, with long-term use, progressive CKD and chronic analgesic nephropathy. 3 points. NSAIDs and COX-2 inhibitors both are nephrotoxic. There's a lot of marketing saying COX-2 inhibitors are nephro-sparing, and that's absolutely not true. It is the prostaglandin inhibition that causes nephrotoxicity, not the sodium part. And again, there's a lot of marketing. Potassium, diclofenac potassium is less nephrotoxic than diclofenac sodium, and that's also not true. And third, all forms of NSAID, whether it's IM, IV, oral, sachet form, oral form, they're all nephrotoxic. So his risk factor was pre-renal azotemia and volume depletion with the use of NSAID. The typical scenario, usually elderly patient on diuretic with heavy use of ACE or ARB. He's not the typical person, but I think with the prolonged disease and decreased oral intake with all of what's going on here, he was prone to non-steroidal nephrotoxicity. Thank you.
Thank you, Dr. Ibrahim. Thank you for alluding to the major problem in Jordan and Darabur, which is the use of analgesia and all kinds of medications without prescription. You go to the pharmacist and he will give you anything. The second thing I want to mention that I discovered just now, myself and Dr. Muhammad Arnaout, that we were in the medical school and we were mentors for Dr. Ibrahim, correct? We asked Dr. Khalid Sharif team to assess the patient. Dr. Fawaz is here, or any of the team. No. Anyway, sure. The thing was that he has no papilledema, his color vision was okay, but he has a periorbital swelling and ptosis. Dr. Ibrahim said that, are you around?
Yes.
Do you want to add anything?
Actually, there is nothing to mention here. probably it's the beginning of some sort of cranial nerve palsy, but not really, since the motility is full with pain on extreme gazes. That also occur with many pathologies like swelling, myopathies, whatever, but not really. Everything is okay till now.
We asked Dr. Mahmoud Al-Assad. Mahmoud, are you around?
Yes.
First of all, if I'm not seeing Ibrahim Sbeih for many years, I will think that by this discussion or about the Sphenoid science, he got another ENT certificate. There are two things I want to add, not about this patient, but in general. First of all, the solitary sphenoid sinus is rare, but as part of band sinusitis is very common. And all the complications which can happen to the isolated sphenoidal sinus can happen to the band sinusitis. So, message to my colleagues in ENT, when you got band sinusitis, you should clear it all. It's not enough to go for maxilla and anterior and posterior ethmoid and leave the sphenoidal sinus because it's far away. That will lead to all the complication which has been said here. The second things about the fungus. There are two things about fungus. There is one identity which is fungus itself, which comes usually with people who have low immune capacity. The other one, which we call it allergic to fungus, which is far more common than the fungus itself. And these people, they should have cortisone because he had got a fungus a little bit in his nose. Then this can cause allergy to the nose, results in polyps, mucocele, infection, everything. Yeah, but I share him the operation. So.
We've been doing surgery for what, more than
23 years.
25 years, yeah. Dr. Muntasir, infectious disease.
Sorry.
Okay. Good evening. Thank you for allowing me to participate in this fun activity. So this patient obviously had signs and symptoms of infection. He did have fever. He had some meningeal signs. Opted to start him on ceftriaxone, covering the meningeal part as well as the sinus part, and flagyl metronidazole, covering possible anaerobes with that air pocket that we saw. It's interesting, as Dr. Mahmoud alluded to, we think of invasive fungal sinusitis in immunocompromised patients. We used to see a lot of them in leukemia patients, particularly acute myelogenous leukemia in the setting of neutropenia. And we used to see fatal cases. Now with the advent of the modern antifungals, we are using them effectively for prophylaxis, and we don't see as many. The other important entity, which I might allude to in my talk, is the allergic fungal sinusitis, much more commonly seen.
What is Aspergillus?
So Aspergillus galactomannan is part of the Aspergillus cell wall, and we look for that antigen in body fluids. We can look for it in the serum, we can look for it in the CSF, or in the BAL, to give us an idea if the Aspergillus or aspergillosis is invasive. If it is positive, it helps to make the diagnosis. If it's negative, So let me talk a little bit about sinusitis, including fungal sinusitis. Chronic sinusitis is a condition contributed to by many factors. having allergic fungal sinusitis, chronic exposure to irritants such as smoking, immunodeficiency states. Obviously, the respiratory tract is colonized normally with bacteria and fungi. And so when the body's immunity wanes enough for these to become invasive, then you get into trouble. Not to neglect some of the other conditions, defects in mucociliary clearance in cystic fibrosis patients, and systemic disorders of Wegener's, now called granulomatosis with polyangiitis, as well as eosinophilic granulomatosis with polyangiitis, Churg-Strauss, and sarcoidosis. Anatomic abnormalities can be disposed to sinus obstruction, and of course, repeated surgery or iatrogenic conditions. Allergic fungal sinusitis, if I may indulge you, are benign reactions to the environmental fungi. There's plenty of Aspergillus in Jordan. Obstruction provides an environment conducive for fungal growth, such as deviated septum, nasal polyps, and inflamed mucosa. So obstruction, again, has been focused upon many times in this lecture. What kind of fungi causes allergic fungal sinusitis? In this study from University of Texas Southwestern Medical Center, children compared with adults, bipolaris had the lion's share, followed by curvularia and some aspergillosis. And that, I guess, forces us to go back to the microbiology days. And so if you wanted to place bipolaris and alternaria and carvularia, they are called domitiaceous molds, and they are septated, they have septated hyphae. Aspergillus, on the other hand, has septated hyphae, and again, it falls under hyaline molds. These are not yeasts, these are invasive molds. And this is important in treatment, which we'll come to here very soon. So 75% of allergic fungal sinusitis is caused by pheohyphomycosis, and 20% with Aspergillus. It's an IgE-mediated hypersensitivity reaction. Most patients have a history of atopy and about half history of asthma. And typically, there's allergic mucin. You know, Dr. Mahmoud and many of the ENT people around this room have seen it. Under the microscope, there's this charcoal-laden crystals that are seen under biorefractory microscopy or in PAS and GMS stains. This is an example of somebody who has allergic fungal sinusitis. They present with proptosis, telecanthus, and malar flattening. And why am I stressing on allergic fungal sinusitis? You get a biopsy or a swab from the nose or sinus, and bingo, there's Aspergillus. Oh my God, let's go and treat the Aspergillus. And it's a different set of different ball game, really. So this is another young man who had polyps in the anterior nasal cavity and were found to be allergic fungal sinusitis. Radiology reveals a mucocele pattern, polyps, and quite similar to infection, but not as invasive. So this huge mass of allergic mucin was causing pressure, and there's a mucocele up here in the right frontal sinus. Extensions may go up into the anterior cranial fossa, the middle cranial fossa, and posterior cranial fossa, but the orbit seems to be a favorite. And here's another example of an allergic fungal sinusitis, huge mass causing mass effect, unlikely cranial nerve pulses. The viscosity is a thick allergic mucin, and that's what you get. Management is surgical removal, and then, as stressed by Dr. Mahmoud, steroids. So we give them steroids systemically or inhaled. And then you call Dr. Muhammad Larnaout when they get diabetes.
He's ready.
He's awake right there. Yes.
About the allergic to fungus, it's said as a rule, if you have a unilateral sinusitis, it is allergic to fungus until proved otherwise. That's important.
Thank you.
As you see from all your
Yes.
unilateral.
Yes, indeed. So the treatment part, we talked about steroids for allergic fungal sinusitis, and I know you wanted me to comment on treatment of invasive fungal sinusitis. While amphotericin B is the gold standard, I think we live in the golden age of antifungals. We have really a number of new antifungals in the azole family. Voriconazole, posaconazole, and isavroconazole that all have excellent CNS penetration, and they are able to kill your aspergillus. Posaconazole will kill mucor when you have invasive rhinocerebral mucormycosis. And so we have a number of azoles that are easy to use and have good CNS levels that we can use for medical treatment. Echinocandins are not great for this indication. Amphotericin B remains the gold standard, but of course, only nephrologists like amphotericin B. Right, Dr. Hiba? Yeah. So recurrence rate is about 6%. And I guess I'll stop here and remind you to be careful what you sniff.
It's nothing to sniff at. We asked Dr. Faras Abaisha to see the patient, of course, and he announced the patient fit for surgery. We got the consent form, which is detailed one, mentioning everything and anything that is related to the patient. If he is a Jordanian Arab, we write it in Arabic, sometimes with some expressions in English. If he doesn't speak Arabic, we write it all in English. And this is, I adopted this form from my training in England. We used to do the same. Let's see the surgery. Of course, myself and Dr. Asad, we've done this for so many years. We're used to each other. When I first came back from England in 1985, I used to do it from A to Z. But then I discovered I'm silly, I'm foolish to do the part that the ENT should do. Here, Dr. Muhammad Asad has led me through the nose into the base of the sphenoid. And here, as I open the floor of the base of the sphenoid, you'll get the pus coming out. This is the right nostril, the left nostril. And we get the cultures. And we send it for aerobic and anaerobic and TB and everything. When I do the surgery, I will contact Muntasir. Muntasir, I'm going to do this. What kind of samples you want? He will contact the lab and state exactly what he wants. This is the suction, and whatever we get the suction, we'll put it in bottles. Aerobic and anaerobic bottles are ready in theater before we start. So we do the sphenoidotomy, we open the base of the sphenoid. This is the rostrum of the sphenoid. And now we are inside the cavity of the sphenoid sinus. We get samples. This is eroded bone, and we send it to Dr. Mufassah for analysis. So we send it for cultures. Look at this piece of bone, which is totally eroded. We send it for histopathology and we send it for cultures. We need both. So this is the cavity of the sphenoid. You don't need to do any more. This is more than enough. So we wash and make sure that we don't have any residual pieces. In this case, we find some one here. Of course, you can use and put the endoscope to see. So that's why we're saying microscopic or endoscopic. It is just the same. But the future lies in endoscopy, cleaning and putting hydrogen peroxide and so on. Okay. Histology, Farsakh.
Assalamu alaikum. We received blood fluid, turbid, and bony pieces. The bony pieces always we have to examine them after decalcification, and the fluid we examine them for different bacterial infection and fungi. Always when we examine for microbiology, we do a panel of sets. At least should include BAS stain. BAS stain, just to enlighten you for the people that are not used to this, we use it to stain for fungi, but also stains for parasites. GMS stain is another stain that stains for fungi, and sometimes we use both, or almost of the time we use both, because some of the fungi they stain either of them, not all of them, not all fungi stain both. Zinlinson stain, we stain them for acid fast bacilli. We use sometimes Giemsa stain also some parasites, and I don't like to use, sometimes you have to use gram stain. I don't like to use gram stain in tissue because so many artifacts happen in the tissue. So I don't like to stain it, but we stain usually use them when we do it in the fluid. In this case, I don't like to comment on the type of the organism, for bacterial organism on gram stain alone. I think it has always to be accompanied by culture because it gives you false positive things. You can see it's the tissue is mostly fat tissue, and there's a lot of inflammatory cells. The most important thing to call something osteomyelitis is to find plasma cells, and there's plenty of them here. You can see them. Plasma cells usually they have eccentric nuclei and eosinophilic cytoplasm. Very important when you come to call it osteomyelitis to find plasma cells. This is another area. This I think BAS stain was negative. There was no fungi in this. This is another area we can see many areas of plasma cells and sheath of plasma cells. This is definite that this is an osteomyelitis and there is no malignancy. Sometimes you see osteoclast. This is not granuloma. This is osteoclast because of the destruction of the bone sometimes, and this is usual. And there are so many plasma cells also there. So we call this acute on top of chronic osteomyelitis, non-fungal or parasite scene. Just a few minutes about the osteomyelitis. Osteomyelitis can be rich osteomyelitis with so many plasma cells, but sometimes can be really difficult. We can call it fibrosing osteomyelitis, chronic fibrosis osteomyelitis, and you see rare plasma cells, but it's very important to look for them. Sometimes we use CD138, which is a immune staining, to highlight plasma cells that are hidden. So it's very important sometimes to see them, especially it is the chronic fibrosing osteomyelitis. You mentioned something as a pathologist, I want to comment on the NSAID, non-steroidal anti-inflammatory. I think many people, they don't know, because we see this as a pathologist, you don't see them as a clinician, unless you are in the GI. We see them not in ulcers, of course they cause gastric ulcers, but they cause microscopic colitis. And many people that are addicted to NSAIDs will develop over the time, especially collagenous colitis. They alter the synthesis of the collagen in the colon, so you can cause collagen colitis. So be careful, NSAID not only has nephrotoxicity, but also has colonic toxicity. Thank you.
So this is the result. It's acute on top of chronic osteomyelitis. These are the cultures that followed: blood culture, urine culture, Zeal-Nelson, gram stain, swab cultures, Streptococcus viridans, and here the same thing.
May I comment on these
Please.
bacteria?
Yes.
So these are oral bacteria. Strep viridans in particular is a group of oral bacteria found in the teeth, gingiva. So this patient had an infection with oral bacteria. Viridans group strep has many species, and they cause gingivitis and other orally related infections.
Chronic bacteria usually are present in the skin. It's a normal flora. So I don't know what's the significance of finding or writing it, because probably this is contamination from the skin.
Sure. As Dr. Mutsal mentioned, he was treated with Rosfin and Flagyl and Megion. We discharged him because he was well, and this is our discharge summary. Again, the usual flimsy, simple 2 lines discharge summary is not acceptable anymore. It is not. Although it is in every hospital in Jordan, this flimsy piece of discharge summary. Patient admitted on so-and-so, discharge so-and-so, collimatomy was done, discharge, nothing. No information for the patient or relatives or any other doctor. So you should have something like this. And I keep saying, discharge summary is started on admission. Once the patient is admitted, you put his history. Once the lab results come, they put them inside, the x-rays results, and then what happens, the consultations, the treatment, and everything. Again, this is not my invention. This is how I was trained in England to do such discharge summaries. Follow-up, 6 months. He went back to Norway to his wife and kids. As I said, he's residing there as a graphic designer. And I asked him to come over to see him. He was doing well. And this is his MRI. Look at this.
Very clean.
And here's the man, completely recovered.
He designed this himself. He designed the radiology.
No. And here he is. He gave me a book about the rhymes and hymns in Norway, which was very, very nice. At the same period, the same month, we have this Iraqi patient with multiple cleansing nerves, 6th, 3rd, and V2. And look at this. This is the one that Dr. Jumam alluded to. He had pan-hypopituitarism. Again, we did the surgery for him. This is what it looked like, and he recovered completely. With this, I finish, and I thank you very much, and I'm open for discussions and comments.
So, as Ibrahim, you mentioned at the beginning, that this disease is mainly in Far Eastern people.
It's common.
It's more common, let's say. And you presented most of the papers are either from Korea, Turkey, India, and
Sure, it is there in every country.
Why is that? Is there something in the
Yes, it is.
or why?
It is just the atmosphere, the humidity.
Is it humidity
Yes.
or
Humidity in Far East and in the Middle East. But it is present in every country. Yeah. I'd like to ask Dr. Asura Saleh, do you have any comment, any تعليق؟
تعليقي انه هذه الجلسه دسمه من العلم رائعه جدا تخلد لك في الاردن فانت الوحيد الذي تقدم. شكرا لك.
بالنسبه للساينوسايتس it's more common in Europe لان عشت هناك وعشت هنا far common for polyps there about less here and the polyps now they say most of it are immunity or allergic to fungus, so it's very common here.
The major complaint of the patient who referred to us in the radiology department for MRI or CT scan is headache. So we find a lot of patients, they have sinusitis or sinus involvement by either sinusitis or allergy or pansinusitis. And sometimes we mention if it is very important, if it is small mucoperiosteal thickening, sometimes also we consider that in our diagnosis. ENT specialists, sometimes they like it, sometimes they don't like it. So I think that sphenoid sinus is very important to be mentioned. Sometimes ethmoid sinusitis or frontal sinusitis, if it is mild, so it is not very important for the patient, but sphenoid sinusitis is very important because as we saw here in this lecture or sometimes in our practical life, we see sometimes it has very bad complication. I want to ask for Dr. Mahmoud Asad
if there is sphenoid sinusitis or pansinusitis with multiple polypoid lesions and very bad sinusitis, when you go to surgery for this patient first, and second, most of the patients, they come to us twice, 3 times, 4 times. They don't cure with medication. So what is, when you go to surgery for these patients?
Indications.
First of all, if it is acute, you have to give him some sort of medication, okay, according to what you find. In the chronic, there is no pre-operative management is not. Usually, the post-operative is important. Now, you have to differentiate between a chronic non-polypoid sinusitis and polypoid sinusitis with polyps, okay? But first, I like to comment on your question about the smoke. Now, MRI, if we going to depend on MRI, most of the people, they have a lot of sinusitis, which is for us because it's not differentiated the bony margin. So it will give you bad impression that it is sinusitis. So we depend mainly on CT. Now, CT, if it is all around mucosal thickening, this is part of, and the doctor, like me or others, he will look at the examination of the nose, and if we find that there is a hypertrophic turbinate, so it must be for the sinuses to be hypertrophic because it's the same mucosa. So what's affecting the mucosa of the nose is going to affect the mucosa of the sinuses. So we don't consider this as sinusitis. We consider it as part of nasosinusitis, which is need to be either allergic or vasomotor or whatever it is. That's why sometimes we don't look at report a lot or take a wait for what reporting. So this is the answer, doctors. Now, for the polyps, we should surgically remove it and then we send it for to find out if really there is allergy by IgE, by RAS test, by breast test, whatever there is. So you can find the allergy, the allergic reason, and then you treat it accordingly, either by desensitization or removal or anything like that. But to just give him the medication before, it's not good to him. Now, some people, which is unfair, they give him a lot of cortisone before, and then he gets very well within 1 week, 2 weeks, 3 weeks, and then he come back more, and also a person like hypertension or something like that. So we advise removal and then go for a treatment. Surgery is not the only treatment for chronic sinusitis with polyps. Surgery can be enough for the chronic sinusitis without polyps. Okay.
Can you comment on, have you seen any cases in your practice of mucoceles of the sphenoid causing endocrine problems? To Jarir, have you seen pediatric cases of sinusitis?
Maybe 1 or 2, but it is in your domain or in domain. We depend a lot on radiology. Really, diagnosis is not really clinical. So you don't blame the pediatrician. You blame my friend here.
Thank you very much. Just to mention that the role of MRI in diagnosis of fungal infection. During the tuated, there is a jet black of the sinuses, which is look like an air. This is diagnostic of fungal infection.
Dr. Hiba, can you enumerate what are the drugs that would cause renal problems? Enjoy.
That's a 1 hour answer, probably. Yeah. So I have to say NSAID would be the #1 abused medications. I've talked to many pharmacists, colleagues, and they give me a staggering number of Volfast and Voltaren gel and Voltaren tablets prescribed on a daily basis. I have to say, in
Sorry, what about the Voltaren patch?
Very good question. So there is a minor transdermal absorption. So in someone with low risk normal creatinine, I would allow it completely. With advanced CKD stage 3 and above, it's absolutely
orally
contraindicated.
or patch or IV?
Correct. And transdermal, correct.
What about antacids?
Antacids, which are either H2 blockers or PPIs. H2 blockers have not been implicated in AKI or CKD, but PPIs, proton pump inhibitors, which we overuse and abuse. Prescriptions are written on discharge with no instructions when to discontinue. So a lot of our patients would consider it one of his chronic medications with absolutely no indication. PPIs can cause progressive CKD, and that's biopsy proven. They can cause hypocalcemia. They can cause hyponatremia. So they're not innocent medications.
What about antibiotics?
I mean, there are more nephrotoxic medication antibiotics compared to other. So any antibiotic can cause AKI as an idiosyncratic reaction or acute interstitial nephritis. Of course, notorious are aminoglycosides in terms of nephrotoxicity, but overused quinolones. Quinolones are the first reaction when someone gets URI or dysuria. Quinolones can cause acute interstitial nephritis and rise in creatinine. So I want to re-emphasize COX-2 inhibitors because many of my ortho colleagues give ortho stating that this is safe on the kidneys. They're not safe on the kidneys and they're not safe on the stomach even, which was actually the initial reason why they were created. Sparing the COX-1, which is mainly in the GI, but still it can cause GI toxicity.
Thank you very much. Dr. Farah, ophthalmologist, have you seen cases presenting to you with mucosal?
I have seen some, but in England. Not
First, did you teach, Dr. Heba?
I don't remember. But I've seen a few in England, Liverpool Eye Hospital, but here I didn't see.
Any comment from any member of the audience, please?
When I was a GP, I want to ask Dr. Mahmoud Asad also. In case of sinusitis, whether if it is acute or a little bit subacute, we were giving vancomycin for 6 or 7 days, those days. I don't know now if it is effective or not.
Yeah, it's effective for Dr. Heba.
Yeah,
it's too busy, right?
Dr. Montasser, you know better than me, but in my experience in international lectures and conference, in Britain they like to give levofloxacin, the catalog. And the American, they like to give the amoxicillin or plus glycolic acid. So everybody is, claim that this is the first choice for treatment for acute sinusitis.
May I close by saying that
yeah,
what you have said is very accurate. It depends on the country that you're treating. In Norway, you use amoxicillin. The United States, fluoroquinolones. In Jordan, either or, perhaps sometimes macrolides. لا مش cortisone. Obviously not vancomycin. Vancomycin is a toxic drug that belongs to the Middle Ages. It would be a borderline malpractice to use it for sinusitis. Although good for, again, our friend.
Any questions, any comments? Thank you. With this, we finish, and I thank you. We'll meet next Wednesday.
Thank you very much.